I'm Dr. Jam Katari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family.
Hello and welcome to the Myeloma Minutes.
And we're going to explore a rather complex area which I suspect will have affected many of our listeners, which is steroids. And I guess there's many things to pull out of considering steroids. But before we get going as to the toxicities, which are incredibly important, can you just explain to me, Jam, what are steroids? Why do we use them so much in myeloma?
I think this is a topic that we were always really excited to do, weren't we? Because the amount of clinic time that is spent talking about steroids is enormous. Steroids are hormones, so our body produces various different types that are needed for many aspects of our normal physiology. Humans manage to work out how to synthesize various types of synthetic steroids, and myeloma for a long time never had any effective treatment whatsoever. Lots of chemotherapies for lymphoma and things kind of came out of post-World War II. But one of the earliest agents shown to have anti-myeloma effect was steroids. So we know that steroids kill myeloma cells, and steroids by themselves can have a significant anti-myeloma effect, and we use them regularly, sometimes as sort of single agents, as we say, to sort of get immediate control for various complications related to the initial presentation of multiple myeloma. But just talking about the history of it, because steroids started really as the first treatment, as treatments have developed, people have used steroids as the backbone to add on different therapies. For decades, steroids have been a crucial part of the armamentarium because not only do they have anti-myeloma effect in themselves, they do synergize with certain other classes of agents in myeloma. And it's only now in 2025 where we're starting to see trials that are now being published where steroids are being dropped early, and there are more novel therapies that don't include steroids. But for many years, the management of steroids and steroid-related side effects has been absolutely a cornerstone of myeloma management. So there are a number of types of steroids that we use in myeloma, but the two main ones, Sally, do you want to go through the two main steroids that we use?
Yeah, so main steroids. I mean, steroids are a bit mischievous, aren't they?
Yeah,
they really are. And just to pick up on something you mentioned a few moments ago, so by synergize, I guess you mean that the other drugs that you give, it makes them work better. Yeah. So they sort of increase, or what we would say medically is augment that effect. So some of the steroids that we use, I mean, particularly prednisolone, which is more commonly used actually across other diseases. It's the milder of the two steroids that we use, and that was largely, that's slightly more old-fashioned, I think. We don't tend to use that so frequently now in clinical practice, but we used to sort of bolt it onto other treatments, for example, bortezomib or Velcade, which we might refer to in future podcasts. But actually, the cornerstone, particularly of controlling an acute presentation of myeloma, and by that I mean someone who's just turned up, they're poorly, they didn't know they had myeloma, they've just been told, and the doctors looking after them or the teams looking after them might need to calm the myeloma down. So for that sort of scenario, we tend to use dexamethasone, which comes with a whole bucket of joy or mischief or just consequence, which I think if you're naive to these drugs, you feel it pretty fast. So they're the two steroids that we tend to use. And I think largely now dexamethasone is a steroid of choice to use embedded within standard myeloma regimens. But yeah, it's brilliant that hopefully in the future we'll be able to moderate the extent to which we need these drugs. And actually there are regimens coming through where they're not really needed at all, which is really exciting. So that's steroids very briefly, but let's explore steroids in a bit more detail, Jam. So you've mentioned that they're part of the natural immune system. Why is that so important in controlling myeloma? They help to kill the myeloma cells you mentioned earlier and sort of calm down the immune system.
Yeah, I mean, steroids, they have a number of effects on the immune system, right? And I think one of the big issues is that they can be, they are immunosuppressive. So when we mention immunosuppressive, it means that it dampens down the immune system's ability to work normally. Okay, so we're going to come to all the different side effects of steroids, but we've started with this one, and that means that over time, steroids increase the risk of all sorts of infection. You mentioned about how steroids are used in lots of different parts of medicine, across rheumatological diseases, lots of different aspects of hematology. They're excellent drugs because they are anti-inflammatory as well, which can be of a significant benefit in someone who's got a bad shoulder. You can inject steroid into a shoulder, for example, or into a knee. And for a number of autoimmune conditions, that immunosuppressive effect is actually helpful because your body is producing an antibody to a different part of your body, which it shouldn't be doing, and then you're controlling it that way. They damp down your immune system, but the key point around, say, aspects of initial myeloma treatment is that they kill myeloma cells, right? And unfortunately, in myeloma, scenarios that we often face are areas of myeloma potentially growing out of your back, out of your vertebra, for example, getting close to the spinal cord, and that in itself causes inflammation, and there can be some swelling or edema. And use steroids, sometimes very quickly you're in a position to shrink away that tumor from the spinal cord because you start attacking the tumor immediately. And they do work quickly, I think, which is a really, really important point. As we go through this series, we'll talk about all sorts of different drugs, some which work rapidly and some which take longer to work. So they're very good at reducing areas of tumor pretty quickly. And that can be very important for pain as well, right? So sometimes we see people in a lot of pain because of the effects of myeloma on the bones and various areas of soft tissue myeloma. You start shrinking that down, pain improves a lot. If the kidneys aren't working so well, steroids can be very, very helpful there initially as well.
Yeah, I think so much of particularly if you're in an acute situation, by that I mean something that's occurred relatively promptly and you need to control quickly to stop more damage or harm, occurring. Steroids can be really useful, and kidneys are a classic example of that. When your kidneys are in trouble because they're clogged up with your myeloma, if you just give some steroids, you can exert some control over that myeloma effect, and that can help the kidneys recover. And that can occur relatively quickly with other supportive measures, for example, like fluids. So they can be very helpful in that I need to give something now because if I don't, this person's going to get more poorly. But also they can allow people to recover a little so that you can then potentially give other drugs as well as mitigating pain. And it's interesting, isn't it? In terms of the pain piece you've just spoken about, it's not unusual. Some people get on really well with steroids, particularly actually those patients who might have other conditions like arthritis, you mentioned rheumatoid arthritis, or even osteoarthritis. On the steroids days, their pain just disappears, which isn't the effect we're aiming for necessarily in terms of the myeloma, but these sort of off-target effects actually aren't necessarily all bad.
The anti-inflammatory effect for various types of arthritis, no, absolutely. And in the renal scenario as well, sometimes people have high calcium levels. Yeah. The steroids bring that down as well. So often your clinician may have given people, we talk about pulses of dex, right? That's a very myeloma doctor thing to say. Now, what we mean by a pulse is we mean a few short days of a very high dose. But I think myeloma clinicians are famous for using the highest doses of steroids that really are used in, all of medicine, really. I think we use very high doses, and other specialities look at us like we are crazy. And to be honest, I think for a while, the reason that was done is because we just didn't have many drugs. And now how we're using them, and it's been changing for a while, but we are getting those doses down very quickly. So when people say pulses of dex, that's what they mean. They mean normally around 4 days of a high dose dexamethasone. And if you've been in a situation yourself where you've had that, it may be because your kidney was unhappy because of the myeloma, or your calcium levels were high, or you were in pain. I mean, sometimes initially when we meet people, dexamethasone can be the best thing for pain, not only for the myeloma, but as you say, for the sometimes the off-target effects as well.
I mean, literally today, whilst we were at our meeting, I was getting messages about a lady who's just been diagnosed with myeloma. And I have suggested she has steroids today and over the weekend to make sure she doesn't develop worsening renal failure. And I can literally pass it on to a colleague over the phone. And I know that steroids are readily available. They're in every pharmacy across the land. Whereas some of our more intelligent, more nuanced drugs take a little longer to get hold of, or you can only get hold of in a clinical trial. So it's that off-the-shelf component as well, which makes them very desirable.
Where we can, we want to keep people out of hospital as well. And it can be a very good way of ensuring that because we're controlling the pain or calcium levels or kidney function, that we're in a position to treat as an outpatient, but monitor very carefully.
Yeah.
Okay. So Sal, you talked about this This patient who was going to start on steroids, so she's a newly diagnosed
Newly
patient?
diagnosed today.
Okay. So what else would you give her with that steroid? Would she just have it by itself, or would there be other medication to go with it?
Well, here we get into, the side effects of steroids, and I think we could literally do a quick fire round. Perhaps we will in a minute of those side effects.
This is what I do to the medical students, when they come onto the ward, because it's unfair to ask them about lots of technical aspects of myeloma. But I'll say, depending on the seniority, I'll say give me 10 side effects of steroids, and depending on how senior they are, it's like maybe 3, 5 or 7. Even the medical students, I say give me a couple. Because they're just so many. But go on, back to your patient. I hope she does okay. But what's she going to have with her steroids?
So she's certainly going to have something called a PPI, which is an abbreviation of something called a proton pump inhibitor, which is another way of describing a medication, often a tablet, that protects your stomach lining. Because if you take steroids, particularly on an empty stomach, but regardless actually, if you just take steroids without this extra protective medication, you're at a significantly increased risk of inflammation of the stomach. Gastritis is a medical way of describing it, or even in the worst case scenario, ulcers in the tummy. So she's certainly getting some PPI with this medication, as well as fluids, incredibly important in newly diagnosed individuals, particularly if you're worried about their kidneys, to sort of flush through the kidneys to help maintain kidney function and hopefully improve it. But also, as the steroids kill the myeloma cells, so to speak, which hopefully they will do to maintain stability, those dead cells don't just sort of vanish into thin air. They have to exit the body somehow, and they tend to do so through the kidneys. And so you need to protect that kidney function as hopefully the myeloma is flushed through. And fluids can help do that. So certainly that, and a tablet called allopurinol as well, which also confers a degree of protection against that kidney trouble, as well as the dead myeloma cells sort of leave the body. So that's what she's having in the first instance. We'll see how she fares. Often people might need a sleeping tablet. You need to keep an eye on blood sugars as well, because it can be problematic. And so sometimes you need to give additional medication to combat particular side effects that might be unique to that individual.
So you mentioned blood sugars, so we should get into that a bit, Sally. So a number of our patients are diabetic when they're diagnosed, and steroids are well known to increase sugars. And there's this thing called steroid-induced diabetes. How do we monitor that? How do we mitigate it? Do we do it ourselves? Do we need friends in the diabetic world? We definitely need friends in the diabetic world, don't we? Because that field has changed remarkably as well, hasn't it?
Yeah. This is something which is really important for us all to be cited on, really, because if you miss a trick here and you don't really think about it, before you know it, the myeloma is beautifully controlled, but the diabetes has gone nuts, and that person's really poorly because they're diabetes rather than the myeloma.
And we've seen people admitted with diabetic complications on haematology wards because of steroids, because their sugars weren't monitored as much as they should have been.
It's a real concern. So steroids can make known diabetes an awful lot worse, and by that I mean really high blood sugars, which can be problematic for the kidneys, amongst other things. Or it can push someone who is borderline diabetic into becoming diabetic. And so the way that we tackle it is we do a particular blood test called an HbA1c, which allows you to look back at somebody's blood sugar control prior to them having myeloma to figure out if they might be at risk of getting diabetes. And for those who are known to have diabetes, you certainly reach out to our local diabetic teams to make sure that the patients themselves are monitoring their blood sugars, and they get the advice as to what to do should their sugars run too high. But you might have a different approach. Is that what you do?
Yeah, no, I mean, broadly that's what we do. I mean, it can be a real problem. And I think the other group that is very difficult is that there are, many people out there who are on the cusp of diabetes, and they get diagnosed with the cancer like myeloma. They have steroids, and we push them over the edge. So we have given them a second disease. So I think using our colleagues from the myeloma team are absolutely crucial. Diabetes is much, much more common than myeloma. So I think we have to understand that they have less time than we do to think about individual patients, but we need to form good relationships with them, give them Christmas presents, because actually monitoring sugars, I think, has a big impact on quality of life. And as we mentioned in our first podcast, with people now hopefully living and clearly living for so much longer term control of other chronic conditions becomes increasingly important. But for those patients as well, I think we try and get the doses down quicker. We use lower doses and try and tailor it to mitigate the side effect relating to the sugars. But some of our patients end up on insulin. Okay, it does happen. Just to go back to the pulse, Sally, of steroids, and your patient had the PPI and the fluids. Did patients often get allopurinol as well for a few days when they start that?
Yeah, the syndrome, the phenomenon of the kidneys slowing down as the myeloma is killed is known as tumour lysis syndrome. I think it's actually quite rare in myeloma.
Rare. Yeah, it's very rare.
But I think you don't want to miss it. And so I think we generally tend to give a short course of this drug called allopurinol, which some of your listeners might be familiar with because it's also used for gout. And that can confer some degree of kidney protection. But I think in reality, the risk of it is actually quite small. But I have seen a couple of cases, so it's always worth considering. And the drug in itself, allopurinol, you don't have to take it for too long. One of its main side effects might be a skin rash, but bar than that, it tends to be pretty well tolerated.
Yeah, but rash, really good to mention that, because if you get a rash in myeloma, we often think allopurinol, cotrimoxazole, which is an antibiotic, and lenalidomide. There are three classics for a rash. Now, unfortunately, there are some people that will be started on all three at the same time. That can be a problem, but I think rashes in myeloma, they're the drugs that we always tend to think of. Of course, that's not an exhaustive list, but they can be problematic. So back to your patient. So she may need a sleeping tablet. So
yes,
can you tell us about dexamethasone and the blood-brain barrier and those sorts of side effects? Have you ever tried some Dex? Sometimes I feel that we should do these things. As treating clinicians, we should have a bone marrow biopsy, maybe. Try some steroids. I've actually had a few patients who said to me, it's like, you do realise that you can't ask me to do this unless you've had one yourself. And they were quite persuasive.
I think it's a very fair comment. I mean, Michael Mosley sadly departed.
Yes.
I don't know if you recall, but he used himself, didn't he, for an awful lot of experimental medical models. I think particularly he gave himself H. pylori to prove the link with gastritis.
So what Sally's saying, if there are any patients that want to do a bone marrow biopsy in Sally, she's absolutely willing to have it done. Just leave your message and we can make it happen. And I'm willing to try 10 milligrams of dexamethasone and then see what happens.
Yeah, it'd be a whale of a time.
So what happens?
Well, so it's essentially this.
Sometimes nothing, right?
Yeah. Are we talking about if someone does a bone marrow meal?
No, we're back to Dex. We're back to Dex and the effects it may have.
So the blood-brain barrier, it's quite an important concept, not least because it's actually quite hard to say without stumbling over your words. Yeah. But essentially, the brain is protected from toxins. That's clearly an incredibly important organ in our body. And there are some drugs that we give which are unable to penetrate this, and actually by that I mean reach the brain to exert an effect, whereas other treatments do pass through this sort of barrier.
Dexamethasone has that special ability to,
Thank you for clarifying that. And this is really important because actually, as you referred to, I think in our previous podcast, some people might develop abnormal areas around the spine or indeed very rarely, but around the brain. And so having a treatment which can get to that area to calm things down, as steroids do, is incredibly important. But one of the downsides of that is they can also affect how your brain might function. And in particular, we notice and we find with steroids that they can give you quite a time of it. Some people really enjoy being on steroids because of the way they interact with what we would medically describe your cognitive function or how your brain works. But what that can actually mean in reality is they keep you up all night, you're pretty busy, you can't sleep. Some people love it, they get a lot of work done. Other people find it actually changes their mood so much that actually they struggle to cope with them at all, even in small doses. And some people are beautifully immune to this side effect for reasons I don't quite understand.
And I don't think it's well understood at all, is it? No. I think it's a really important point. Some people, you think that you just have a feeling that they might not tolerate steroids and they're fine. And other people just say, I can't cope with it. So can people have any sort of mood changes, or does it make people feel happy or sad or everything in between, or what does it do?
I often refer to it almost as if you've had a little bit too much to drink, but it's a bit more than that. But it can change your behaviour in a way that we're very familiar as a culture, as alcohol does. So, for example, some people might become incredibly chatty. Some people might get quite angry and quite aggressive because of the hormone effects of the steroids. Occasionally, fortunately very rarely, you can develop, true psychological distress, a sort of psychotic, type syndrome, which I think both you and I have certainly seen. And basically everything in between. But often, actually, to really figure out what's going on, you've not only got to ask the individual in the room, but also the person sat next to them, who will tell you a totally different story. Yeah. But would you share that? And do you have any, any anecdotes and stories to share?
I mean, the number of things that you hear people with steroids doing, and you realize that they're, cutting the grass at 11 o'clock at night, for example, and just the effect it has on sleep as well, I think can then just multiply the sort of what we call the neuropsychiatric side effects. Often there's nothing worse than not being able to sleep. And sometimes if patients have also had other drugs like, bortezomib, and they have a bit of neuropathy, we're just giving people a cocktail that just makes them miserable. So people sometimes say they can get to sleep, but then they're up from 1 and then they can't get back to sleep. The other thing is, as you say, give it impulses. So sometimes, as you say, people are great on it. Or as you say, they get a whole, I love being on it because I clean the whole house and I do this, but actually, you ask their partner, it's like, they're erratic and angry. And I think a really important part of this is that, well, these are the drugs you've given me, so this is what I need to be taking. People need to understand that there's loads of wiggle room actually now with steroids, and there's lots of things that we can do. The other thing that happens is some people get a dip, right? So they're fine on them, but then maybe not the day after they stop them, but the day after that, they just absolutely crash. And that is horrible. Like people say, I just feel miserable. I'm so down. I can't do anything. And again, it's just, I think the body readjusting after a pulse of Dex. So sometimes we tail them off, don't we? So we just give a little tail. So say on the 4th day, if you're on 4 days of steroids, you might do half the dose on day 4, a quarter on day 5, and then a quarter on day 6, just to tail it off and even it off. Some people are just very sensitive to the neuropsychiatric side effects. Do you think a past history of depression or psychiatric illness, it makes us more nervous about using them, which is understandable? Do you think it increases the risk of toxicity?
I suspect so. I mean, I suspect some of these sort of, the sort of psychological and psychiatric side effects are underreported.
Yeah.
But it really is rough. I think particularly, I'm often very concerned about that downtime, because actually, particularly if, some of the treatments we give, you might need steroids, high-dose steroids once a week.
Yeah.
And so you're spending 3 or 4 days once a week feeling absolutely rotten, miserable, low, in a way that you can't really pull yourself out of. It's so good to hear about the breakthroughs whereby you can minimise and modify and get rid of the steroids altogether, because I really think they're just quite dirty drugs. But it is hard to predict. So I don't know if there's that link. I suspect so. I get nervous about it, but I don't know for sure.
There's an old myeloma clinician tale that if you take your steroids the last thing before you go to bed, the stimulatory effect kicks in after you wake up. Now, I'll be honest, I do tell patients to try this. Because it's one of those things that you can try, and if it actually works, which it does in a few people, then you can keep doing it. And if it doesn't, you can ditch it very quickly. The evidence is pretty scanty and it's anecdotal, but for some people that does seem to work because other people, when they take the steroids in the morning, they're fine, they get to sleep, but it's almost like then the stimulatory effect peaks sort of at 1 a.m. So that's something that we have done occasionally. But we're very open in lots of situations to, I think, reducing the dose.
Absolutely. And particularly to do so pretty promptly, particularly if you're dealing with significant psychiatric side effects. I mean, some people are just simply unable to tolerate them full stop. They become way too poorly or way too confused. And then you have to think more laterally or give alternative steroids to hopefully, work as an adjunct to their treatment.
And people say to me as well, it's like, well, why do I just have to take a really high dose for 4 days in a row? If you think this is the right dose, can't I just even it out over the month and just take like a low dose continually? So why is that not a good idea, Sally?
Interesting. It's kind of almost like you need a really big, short, sharp shock, big hit, shock the myeloma cells. And as you do so, they become more vulnerable to the steroid effect and also the other treatments they're given. So it really is that big, slightly like using a sledgehammer to crack a nut, but it does work and is proven to be effective. And also, if you take the steroids every day for a whole month, your body adapts to that. And so it suppresses your natural ability to make steroids. And that comes with its whole range of complications in the short to medium to long term. So that's not ideal either. So there is thought behind it. I promise there is method to the madness, even though it may not feel like it at the time. People, when they think of people on steroids, they think of the slightly upsetting view of people who are very puffed out and have lots of swelling in their tummy and their legs and they bruise easily, and there's this condition called Cushing's syndrome where you produce too many endogenous, so steroids from within inside you, and it's
by taking external steroids every day, you can kind of mimic that. And because we use steroids in short, sharp bursts, we tend to, thankfully, our patients don't often get Cushingoid.
Yeah.
But for some people who've had to take daily steroids for whatever reason, they can end up with that kind of look, which no one wants, but is very reversible.
Yeah.
I think is an important thing to say. Just finish with the psychiatric. Well, I don't want to say psychiatric. The mood side effects.
Yeah.
Sometimes people say, "Can I just change steroid?" So is that a thing? Do we do that as much as we should? Should we do it more?
Very good question.
Yeah.
I don't think I do. I tend to lower the dose.
Yeah.
I tend to go far lower much more quickly, and actually, increasingly, I think a decade ago, it was standard that people get 40 milligrams for 4 days. So that's
twice a month, right?
Twice a month.
Twice a month. Yeah. So 8 days out of 28. Wow.
And people look at you like, you really expect me to take all these tablets? Because that's 20 little white tablets every day for 4 days, every fortnight. It's a lot to remember. It's a lot to actually swallow. Never mind the impact of that. Now,
that kind of highlights how big the dose is, right? It's like the people who make these drugs saying these are potent drugs. It's very hard to get tablets that are bigger than 2 milligram tablets. So you're right. You end up taking, it's like you want me to take 20 tablets.
Yes.
And how many times have pharmacists that haven't worked in myeloma before, it's like, this must be a typo, right?
Yeah.
I just want to check this is the dose. No, it's like, no, that's the dose.
That really is the dose. And what wait for the consequence. But so I rarely now go with 40. We're running some national clinical trials at the moment, which I'm sure we'll speak about in another podcast. And embedded within those trials, partly because there's a historical standard of care. And by that, I mean, because people have done so in the past, it's very hard to do differently in a clinical trial where you're comparing what's happened previously with what's happening now. So people are often exposed to higher doses in clinical trials, but in the real world, I think physicians, and certainly myself, I don't go in with those doses. I do 20, particularly in older people. They might be more vulnerable to the cognitive, psychological side effects, or even lower than that, and 10. And I certainly, when I'm seeing a response, I pull back quite sharply. I decrease down pretty quickly and stop when I feel comfortable and I've got a good response.
Yeah. In some situations, you could change to prednisolone, which doesn't cross the blood-brain barrier in the same way.
Yeah.
But even with prednisolone, some people will say they can't sleep, it's affecting my mood. I think in some people, you do get an element of prednisolone or prednisone, as our American friends would say, crossing the blood-brain barrier. Yeah. So where are we? We've done sugars and diabetes.
Yeah.
We've done the neurological and neuropsychiatric side effects. It increases your appetite.
Yep.
Okay, which again, you put that together with the changes in blood sugars, that's not a great combination. Yeah. And unfortunately, sometimes that increase in appetite is an increase in, like, I just need to phone Domino's.
Yes,
And it does happen. I always have this memory of this slightly different disease, this young man with acute lymphoblastic lymphoma. And they have lots of dexamethasone in that. And when he was on his steroids, I mean, the pizza boxes were just like piling up in his room when we were at UCH, actually, in the tower. But it increases your appetite. But again, which can sometimes go with, as you say, it can irritate the lining of the stomach.
Yeah.
So, your indigestion can get worse because of steroids and your increased appetite and your sugars. So all these things can interact in a difficult way.
Yeah.
I touched on those Cushingoid features and edema. Sally, so swelling, tell us about that, because that's amazingly common.
Yeah, amazingly common,
Even
very problematic, particularly around the ankles, what we call dependent edema. So people find that in the morning their ankles are a little slimmer, and as they go along throughout the day, they get more and more swollen. Can get very, very uncomfortable.
It's a really horrible side effect, and people talk about it a lot because it's not nice, is it? So what do we do for it?
Yeah, so depending on the individual that has that problem, you might want to give water tablets to try and shift some of that fluid if you really don't want to pull back on the steroid dose. But often you might then dose reduce the steroids. And the other thing that we are always quite mindful of, particularly given the drugs that we're now giving to all our patients, is also making sure their legs are swollen. What else could it be? Could it be something else like a blood clot? So often the leg swelling in itself, even though your hunch is 9 times out of 10 this is steroid related, you have to exclude other stuff as well when you see those people in clinic. So, sometimes the swelling can extend all the way up to your tummy. You can feel quite puffy in the face, as you've referred to. Around the back, it can be very unpleasant.
Often have fluid in all the wrong places, right? So water tablets can be extremely useful for short periods of time. We often use something called furosemide, which is very effective, but can affect the salts in your blood, which can be a little bit irritating. The effect of furosemide lasts 6 hours.
Yeah.
Okay. So the brand name of furosemide was Lasix, right?
Yeah.
Lasix, Lasix, because it lasts 6 hours. That's
Oh, I didn't realise that.
random
There
fact
you
about
are.
furosemide. There you go. Honestly, I've got better chat than this sometimes.
I need to go out more, John.
Yeah, no, seriously, I definitely need to get out more. Furosemide can be used for, as you say, you've got to rule out a DVT. Sometimes if people have low protein levels in their blood, they can be swollen as well. So there can be confounding factors. But again, you stop the steroids, you can improve that significantly. Another confounding factor, and again, it links into another side effect of steroids because it puts up your blood pressure. Okay, now part of that is related to, I think, fluid shifts as well. So hypertension, measure your blood pressure. And again, a lot of people are on a drug called amlodipine for blood pressure. That causes ankle swelling as well. So actually thinking about whether they're often on a drug called amlodipine, because then sometimes if you change that, then maybe it's not the steroids. So all these things are kind of worth thinking about. So swelling is an important side effect. So good, we're getting through the side effects, Sally.
Oh, there's many more to go.
Come on.
Don't hold back.
Start from the top and work downwards. Eyes. Let's talk about
eyes. Are a big problem.
Let's talk about the eyes.
So 2 things about the eyes, really. First of all, the steroids can cause cataracts, particularly when you use them long term. Now, myeloma tends to be more common in older people who may or may not have a tendency towards cataracts, but it can certainly, hasten the development of cataracts, which can be problematic. But you tend to see that slightly further down the line. But also steroids can cause a change in the sort of the fluid density of the lenses of the eye. So people often find when they're on steroids, particularly their reading glasses, they might need to change their prescription. And they really do notice that. It tends to be within a month or 2, if not earlier than that. So can be quite problematic and actually often overlooked, I think, in clinic as well.
Yeah, absolutely. So eyes are really important. And when we come onto therapeutics, there are newer therapies such as belantamab, which have their own eye toxicity as well. So people have had steroids and toxicities related to that. And then you have other toxicities. The eyes cause such an important organ. Yeah. So if we keep moving down the body, mouth, okay, oral thrush.
Absolutely.
Okay, so a fungal infection of the mouth, which is pretty common. Yeah. The advantage of pulse dex is that I just don't think we see it that much. I'll be honest. It feels like one of these things that's more of a continuous dex thing. But if people say, you go into clinics like, my taste has changed, my mouth is coated. Sometimes you can just look in the mouth and make a diagnosis and it's very easy to treat. But a relatively easily treatable side effect.
Yeah, absolutely.
But it can be horrible.
Yeah, absolutely. Very unpleasant and can cause weight loss and such like, which is not ideal and just very uncomfortable.
Okay, bones.
So bones, this is interesting, isn't it? And this is a really complex area, which we'll speak to another time. But, myeloma weakens the bones, but we know that particularly long-term steroids can also cause weakening of the bones and osteoporosis. So on one hand, you might say steroids help your bone pain, for example, if you've got arthritis. But if you were to take a certain dose of steroids every day, you would certainly develop weakening of the bones or an osteoporotic profile. And often myeloma can cause osteoporosis as well. So arguably you're giving a treatment which might make one of the side effects of myeloma a little bit worse. So we have to be sighted on bone disease in myeloma for lots of reasons, but not least also because we give steroids, albeit that in these pulses where the risk is less, but it's still there. So that's, steroids and bones, it can be a problem.
Yeah, so as you say, I think part of the way in which pulses were developed, because it was clear that you had to use quite high doses to get the myeloma cell death, but also some of the side effects are less problematic when you give steroids as pulses, and I think that's absolutely correct. Right? So we're working our way down the body, bones, heart. Okay, so steroids can unfortunately cause heart failure. We do see it again, not as commonly with pulses, but it's well known that chronic exposure to steroids can cause a steroid-induced cardiomyopathy. Our cardiology colleagues and friends will tell us that. And again, that can be exacerbated by fluid being in the wrong place, basically. How are we doing? I think we're getting there.
We've missed a biggie though.
Yeah, we have.
It's so hard to miss a few. But infection, I mean, I think this is also really important with newly diagnosed patients.
We touched on it, but we should absolutely talk about this. Yeah.
So, I mean, of course, there's infection, which we've just spoken about in the mouth. Yeah. But, when you're particularly when you're first presenting with myeloma, your immune system is weaker. And then we give drugs to combat the myeloma, but steroids in particular can weaken your immune system further. And so, again, you get into this vicious cycle whereby the drugs you're giving to help you can actually make you more poorly and more vulnerable vulnerable to infections. And so we often give antibiotics, don't we, for a finite period of time whilst people are receiving their treatment to mitigate that risk to some extent, but we still see infections crop up. And it's often quite difficult to ascertain would this have occurred with or without the steroids?
Yeah.
Was it the myeloma or not? Was it something else that happened? But the important thing is that we figure it out and get on top of it quickly.
Absolutely. And there are a number of strategies to look into that. Certainly for allied diseases, patients that are on steroids and have low blood counts, low neutrophil counts can be at risk of what we call invasive fungal infections. Thankfully, that's something we see very rarely in myeloma, because a lot of our agents, neutrophil function is good, and it's not something that we have to often think about in too much detail. But if you're on prolonged steroids and people have prolonged low blood counts, it's something as a hematologist that's always in the back of your mind. And we talked at the beginning, didn't we, Sal, about just the evolution of sort of therapies in a way, starting with steroids and then you add on things. And still in 2025, steroids are still one of the backbone drugs in transplant eligible patients, for example, just 4 drugs, and one of them is dexamethasone. Where is the field going now? You go onto social media like we all do. There's a Down with Dex campaign in myeloma, right? Down with Dex. Are we in the last decade of Dex?
I certainly hope so. Wouldn't that be wonderful? I mean, it's hard because actually this drug...
It sounds good though, doesn't it? The last decade of Dex.
Death to the Dex.
It will always have a role.
Yeah, I think so.
But whether it's a role long term, what do you think?
I don't think so long term. I think the drugs which are coming through are really exciting, and they augment the immune system, and by that I mean they wake up your body's natural ability to fight the myeloma. So that the drugs like steroids actually, which then might work against them through suppressing that effect, are going to fall off the radar, I hope. But I think, these have still been, the backbone of treatment for decades now. Still do have a role, particularly as I referred to a few moments ago about in that acute settings when you need to give someone treatment quickly, you can get hold of them quickly. But I think more long-term, treatment going on and on and on and getting all these side effects and not knowing how to get rid of them, those days are gone, I hope.
You see it in the field already, like with some of the treatments. So we're going to do a whole pod on bispecific antibodies, BCMA bispecifics, but we have access to these in the NHS now. And after cycle 1, if people are tolerating them, there are no steroids in this regimen, and people love that. It's not like these drugs don't have other side effects, but there's no steroids. There was that other, just for our older patients who are not transplant eligible, there was that lovely study that the French did that they presented at ASH in December, where you get steroids for the first 8 weeks, but then basically is a 2-drug combination with no steroids against lenalidomide and steroids, and the outcome and the toxicities were excellent. So there are studies now being published where Dex is only used initially to sort of mitigate potential reactions and allergic side effects and things like that, which steroids are actually very good at doing as well.
I agree.
So the field is hopefully already moving in that direction.
And I think this is quite an interesting area, because I think actually the research is catching up with what we have been doing on the ground for years. For a long time now, we've been gently nudging these out of the clinic because of the toxicities. The people that we look after, we want them to have a good quality of life, as we've mentioned previously.
Absolutely.
The research is now showing actually you can do that confidently without jeopardising outcomes as well, which is really exciting.
But then say if someone comes to you in clinic and they say, I want the full dose of all these drugs, okay? Because I've had a look and I want to be in remission for 5 years, and if I don't get the drugs the way they were given in the trial, then I'm not going to have a 5-year remission. I might relapse after 2 years, and I'll put up with the side effects. It's fine. How do you sort of approach that kind of conversation? Because it does happen. Some people ask about doses, don't they? It's like, I know I'm getting some side effects, but shouldn't I just put up with these side effects because I need the drugs to work for a long time?
Yeah, I mean, I think that's a really difficult but interesting conversation. I tend to focus on sort of quality of life. I think that should be paramount. And also, you don't necessarily need to have the steroids to get the most out of your drug regimen. In fact, it could be the opposite. If, for example, you're on long-term steroids and you develop an infective complication, that could really set you back in terms of your recovery, how you're going to fare, what treatment we can give to you in the future. So I think, it's a nuanced conversation, but it's not that black and white and that I must do as a trial did, because the real world is not the same as a trial population. And so you need to take each person as their own individual and on their own merits, really. I guess if someone was an assistant, I would clearly respect that, but I think it would be a long conversation around it. And I would also, to be frank with you, I would remember that conversation because I would be concerned that that individual may not share other toxicities with me, which could also impact on their, their health, their well-being now and today and tomorrow and so on and so forth.
Sometimes people do hide toxicities.
Yes, agree.
And I think that's something that we really don't want to happen.
Yeah.
And part of it is maybe personality. Part of it is that we don't get enough time with people in appointments, especially follow-up appointments. As we've talked about before, we're not capturing how they're feeling day to day outside the clinic room.
Absolutely.
And we don't have a summary of how they've really felt since their last appointment. And we hope that this will change. But there will be many people who have been listening to us over the last half an hour or so who will be on steroids as part of their regimen for myeloma, wherever they are in their treatment journey. So when they go back to clinic, what do they need to ask their clinician about their steroids?
Yeah, so I mean, there's a lot to explore here, not least the side effects, which perhaps we should summarise in a minute, just to make sure we sense checked with everyone who's listening, whether that could be an issue for them. But also, really, do I need them? A good example of that might be a drug that we frequently use called daratumumab. Daratumumab is now given to lots of patients, particularly when they first find out that they have myeloma or indeed at relapse. Daratumumab can cause side effects. When you first have it, you can react to it. So people often get steroids to calm down a reaction. But after the first couple of doses, the likelihood of reacting is minimal, yet often the steroids continue. And so actually there's
People
lots
just don't cross it off.
They don't cross it off.
But also, it's funny, they don't cross off the paracetamol either.
Yes.
They don't cross off the, with Piriton, we give three things.
That people
and
don't
we
need.
barely see side effects. And it's amazing how many times these things don't get crossed off, right? Yeah.
So even if the treatment you're receiving doesn't explicitly have steroids in its title, they may still be sneaking in somewhere. So find out about that. So think about the side effects, and if you're getting any of them, consider whether you are actually having steroids surreptitiously. No harm intended. They just may not be necessary. But if they are intentional, do you really need as much as you are getting? And if you do, how can you minimise the side effects? And is there any sort of end date to that dose? Do you really need to continue on them for years and years? I would suggest not in nearly all cases. And in which case, when can they be adapted and sort of stopped?
The studies that are now being published really gives us confidence in stopping steroids. And even the simple study that was probably published 10 years ago, that if you give lenalidomide with 40 milligrams of dexamethasone and it was randomized to lenalidomide plus 20 milligrams of dexamethasone, there was no difference in outcomes.
Yes. Yeah.
And that was a beautiful study by Vincent Rajkumar from the Mayo, just asking a very simple question.
Yeah.
And again, I think because he had been listening to what everyone was saying about high dose steroids, the doses that we don't use anymore. Because actually, genuinely, I can't remember the last time I prescribed 40 milligrams of dexamethasone.
It'll be in a clinical trial.
It probably will be in a clinical trial. You're right.
Yeah.
You're right. But in standard of care, I don't use 40 ever.
No.
So I think we have much more confidence that it doesn't negatively affect outcomes with modern regimens.
Yeah.
And we should reduce doses, not aggressively, but sensibly. And as part of the checklist for any patient we see in treatment in a follow-up, there's a whole bit around what toxicities of treatment are you getting?
Yeah.
Are they toxicities I'm seeing in the lab, like from blood count or liver function or renal or whatever it is? Or are they, what are the dex side effects? Are you getting any? Look at their partner. See if you get a lot of information, right, from looking at their partner or friend or relative. It's like, hold on, this is not the same. And then just the mitigation strategies we talked about, reducing doses. You could try and take it at night, potentially. You can abandon that quickly if it doesn't work. Tailing off if you get a bit of a steroid crash. Swapping out dexamethasone for prednisolone, also something that you can do, or whether you need to be on steroids at all. As you said, are they part of your pre-med that you don't even need anymore, for example?
So as we wrap up in the last minute, let's do the head, shoulders, knees and toes, work on the body, and let's just refresh ourselves about the toxicity. So eyes, cataracts and change in reading.
Yeah, oral thrush.
Yeah. Cardiac toxicity or heart toxicity, so that might be high blood pressure, or in rare cases, heart failure. Yeah,
so bones, osteoporosis with chronic exposure.
Yeah, indigestion, and in rare occasions, more serious sort of ulcers in the tummy.
Yeah, increased appetite, which can go along with that. High blood sugars.
Yep, diabetes and all the problems therein. So make sure your blood sugar's been looked at.
Yeah, the neuropsychiatric side effects, increased mood, depression, sadness, anger, happiness, anything. And sadly, sometimes all of those things in a single day.
Yeah. Increased appetite. I don't know if you just mentioned that.
We mentioned the increased appetite,
Increased appetite, swelling of the ankles, and general fluid retention, and often weight gain as well. I forgot to mention that. That can go hand in hand with fluid retention.
Yeah, and more broadly, immunosuppression and increased risk of infection.
I think we're there, aren't we?
I think they are most of the major ones. And then, of course, there's two other important things: is that you're going to have a bone marrow biopsy, and I'm going to take at least 10 milligrams of dexamethasone and
not record a podcast afterwards,
and then not do anything afterwards, probably. But I guess an important point to make, just what we were talking about right at the beginning, is that these drugs still have a vital role, and in certain scenarios they absolutely make huge differences. But when you're there in the clinic, it's like, is it the right dose? Do they need to be on it? How long do I need to continue it for? And have I gone through all those kind of side effects? So check in with your team. See what they say. And thank you for listening to this episode on steroids.
Thanks all.
See you next time. This has been the Myeloma Minutes. We hope that you found today's pod engaging, interesting, and above all, useful and understandable. Please remember that this does not constitute medical advice. Thank you so much for listening. Please do feedback on what you've enjoyed and what you'd like more of. You can email us at themyelomaminutes@gmail.com, and we'll see you at the next one. Bye.